Look, thank you very much for coming along today. My name's Alan Philp. I'm the Director of the Prevention Policy Section in the Commonwealth Department of Health. I look after population health and sport. That's the division that we sit in, and I look after prevention. And one of the things I wanted to talk to you today was about our national strategy that we're talking to the community about, as well as professional people around the new breastfeeding strategy. So it's fantastic that you're all here. My background is I trained a few decades ago as a nurse in WA. So I trained as a general nurse, and then I had the absolute privilege of working and training as a midwife at King Edward in the early 80s, and worked at King Edward for a number of years, delivering lots of babies as well as some of my own children, and then had the opportunity to work up in the Kimberley part of Western Australia where lots of other deliveries occurred, and then I came down and studied at the university and did a Bachelor of Health Science and then did a Master of Public Health. And then I moved into the sort of population health area where I looked after for the state government HIV clients for the recalcitrant area of HIV, where we try to manage recalcitrant HIV clients in WA. And that was quite a challenge in terms of the work. And then I moved into state health in WA and worked for the state health for a number of years in a range of areas. And then, as my state health colleagues would say, I moved to the dark side and I moved to Commonwealth Health. And actually, as a nurse, I thought I knew something about the health system until I realised when I worked for Commonwealth Health, I didn't know very much at all, because in fact it's a whole new world. And that's the world that you work in terms of primary care. So I think it's fantastic that you work in primary health care, because I think it's actually an enormously challenging, yep, we've got it going yet? No, enormously challenging area of work, because in fact it is a coalface. And the future of health is in fact in the community and not in the acute care system, or well, that's where the noise comes from. So I spent 10 years in the WA office looking after Aboriginal and Torres Strait Islander health as well as general health. And then I had an opportunity 5 years ago to move to Canberra. So I took up steads and moved to Canberra, and I've missed the West Coast beach ever since, really. And so I look out here, well, you don't get to look out, I get to look out in some nice water and that sort of stuff, but in Canberra we're landlocked. And my wife tells me this morning that she had to scrape the ice off the car to get to work this morning because it was bloody cold. And you get to realise the cold weather, as I heard that snow is coming to Hobart in a little while. But yeah, so it's certainly Canberra life. And I've been working in the policy area this last couple of years and had this fantastic opportunity to look at the whole issue of women's health and men's health, but more importantly, looking at the issue of breastfeeding. So I'm going to talk you through the strategy and the work that we're doing, because it's really, I think, very important work, particularly for new mothers and babies. And I think the work that you do in the primary care area, you'll be coming across many of these new mums who come in to see the GP. Maybe they come in to see them for immunisation, but maybe they come in to see them because they've got nowhere else to go. And in fact, you're often the first port of call and where the urgency is. So we're going to talk through the strategy. I've handed out the actual document itself, and there's a little bit of things, so we get to sort of tic-tac on a few things, and hopefully we'll get to do the next bits. So this is really the highlights about how we've got to this point, where we are today, and where we are next. And for many of you would understand that issue of, yep, I'm a rather full mum, and then, the baby comes along and very happy. But I suppose at times you don't necessarily see those two happy faces, really, do you? You probably see the unhappy face at the beginning or the unhappy baby there as well. In terms of how we've got here. So in 2007 there was a Senate parliamentary inquiry into the health benefits of breastfeeding. And it was known as Best Start when they started to look at the actual overall. And one of the recommendations coming out of that proposal was that the Department of Health coordinate and oversee the implementation of a national strategy to promote and support breastfeeding in Australia, including the provision of leadership in the areas of monitoring, surveillance, and the evaluation of breastfeeding data. So as a result, that in the Australian Health Ministers Advisory Council endorsed this strategy in November of 2009, and it was further endorsed by the Council of Australian Governments, the COAG Health Council, in April of 2010. The resulting implementation plan had 10 action areas based on the goals and objectives of the strategy. And it was an internal document that we in fact used in health, and it wasn't actually available publicly, but we can now say that we've actually put it up on our website for people to actually access. So this plan, and this is a very busy slide, but I just expect to really just talk about the headline bits, and there's a little bit in the bottom part of it, but certainly the headline indicator stuff talks about the 10 areas around the work that we're doing. The first one is the monitoring and surveillance. and that's looking at really about how we actually do understand a draft set of national breastfeeding indicators were published by the Australian Institute of Health and Welfare, and in 2010 there was a national infant feeding survey that looked at the work around that. We would like to be doing those surveys regularly, but they're very expensive. So in fact, we've got a real gap in our data at the moment, and this is where you may come into sort of helping us in the future. The next area was health professional education and training, and the government funded the Australian Breastfeeding Association. So many of you may well refer your patients to ABA. Great helpline, peer-based support, that women will go there and actually get some support. So ABA have been ongoing funding since the strategy began, and there's a little bit of politics on whether they get money or not, but essentially they're getting $1 million a year to provide a national service, which we think is important. The NH&MRC released the infant feeding guidelines for Australia, and people would know that in terms of the infant feeding guidelines, exclusively breastfed up to 6 months, introduced solids from 4 months. A little bit of politics around that because of the allergy issue that's now come up that they're seeing, but essentially it hasn't really changed. The allergy people have just said, yes, you can start to introduce solids around from 4 months, but essentially we're looking at trying to be exclusively breastfed up to 6 months. And they also look to amend the Sex Discrimination Act, so to stop the discrimination of women who breastfeed. The culture hasn't changed. We're still at barriers. And I'd be able to tell you as nurses, if I was to talk about discharge planning, most of you would go to sleep and go, yep, we've been talking about discharge planning for, I started in 75. We talked about discharge planning then, and I bet you're still talking about discharge planning now, because you would have patients that would turn up from hospital that would tell you, I've been in hospital last week, and you go, and what did they do? Oh, they changed all my medications. To what? We don't know, because in fact you don't get that level of information. So the health system still has to be responsive, I think, to in fact the patients and what their needs are. But certainly in terms of discrimination, we think the changes to the Act were important, and also there was some physical eating and physical activity for early childhood to get up and grow healthy eating. Health ministers were also, under the banner of supporting breastfeeding in environments in the workplace, there was the Change to the Discrimination Act, like I said, but the other areas was support for breastfeeding in healthcare settings, and the BFHI initiative, the Baby Friendly Health Initiative, that now is in place, and in fact hospitals or communities can get accredited for BFHI status. And so there's a bit of encouragement around that particular bit of work. There was also Australia's response to the World Health Organisation's code on the marketing of breast milk substitutes. And I can tell you in this room, that's an issue of contention all the time, because what actually happened is the women in the community are getting inundated with formula-fed information when in fact breast is best. But in fact they'll be told by the marketing companies that in fact the alternative is fine. And in fact you'll have many of your patients or their mothers that will tell them, no, I didn't breastfeed, I formula fed and you're actually okay. So there's that real dilemma at the moment. We know breast is best, particularly because of the natural elements that are actually within the breast milk and the importance. But it's quite a challenge for us to actually be against that wave of, and mothers wanting to do the best, as all of us, for our children. So they'll think this is actually okay, and thinking that, you know, it's actually marketed well. So there's the issue of what we call the MAFE agreement, which looks at the whole advertising area. And also the donor milk banks. Again, growing, there's only 3 milk banks in Australia, and at the moment they're essentially run out of the Red Cross within the major teaching hospitals, but I hear places like Tasmania have an issue of getting milk from milk banks. They in fact get theirs from Queensland because of the way of bringing milk into the country, that they can't get it out of Victoria. But milk banks we think is a really important, particularly for the neonates. But many of you may know that in fact across with Facebook, that there's lots of women out there in fact sharing breast milk in terms of their local community groups and doing those sorts of things. And while some people think that that's absolutely terrible, it's going to happen independent of what health professionals actually think. And it almost goes back to the early days of the wet nurse, doesn't it? It really goes back to, and this woman was telling the story about this woman that was in a party and a number of babies around. This baby started crying, so she picked up and fed it. It wasn't her baby, it was somebody else's baby. Well, hang on, what's going on here? So that people are quite confronted with that issue of somebody else feeding somebody else's baby, and we know that. I certainly worked in as a midwife in a hospital, and you know, babies go out to feed, babies come back, oh, that baby there, and that's not that mum, and what do we... These days there'll be a national inquiry about it, but in days gone by, people just moved on and let bygones be bygones, those sorts of things. Breastfeeding support and priority groups, expanding new directions, mothers and babies for Aboriginal and Torres Strait Islander health. So health has actually invested quite a significant amount in Indigenous Aboriginal and Torres Strait Islander health, and we see that that's a particularly important area of work, and you may well come across that in your work yourselves. Clinical practice guidelines for antenatal care, breastfeeding information and support during antenatal visits, so that women are much more making those informed decisions. And with most governments, they'll say people want choice. And so the issue is there, we've got to have choice, and we can't marginalise women who don't want to breastfeed, particularly for people who are going back to work. That it is a very difficult process to in fact go back to work and continue to fully breastfeed your baby, because we have a workplace where the room for women to breastfeed is just a room without running water. It's really almost just like it's just a room without any windows. It's not actually satisfactory. You actually need a properly set up, and we know workplaces need to actually undertake that, and it's still a bit of a challenge around the place. There's a continuing of care referral pathways and supportive networks. So looking at where children go, and the pregnancy baby and helpline. So you might have, again, referring people to actually where they get access to information using the helplines that are actually online. And finally, the education awareness, including antenatal education, and Royal Women's in Sydney have done a book that we hope to sort of propagate and get actually out there much more. So that was the implementation plan. We think that it probably wasn't actually done that well. The criticism of the strategy was its inability to evaluate the success of the outcomes due to lack of nationally consistent data. We can't really tell you very much about the data. In fact, if I look at the data now for you, this is the proportion of children currently breastfed by age at child survey in completed months. So this came out of 2010 from the survey that we funded the Australian Institute of Health and Welfare to do. And one might look at that and go, yeah, well, maybe at 6 months it's actually not too bad, but this is just breastfeeding, not exclusive, just breastfeeding itself. But you'll see most women may well leave the acute care system 95% exclusively breastfeeding at that time. And as you see, it drops out quite a bit, down to the 2-year-olds around sort of 7% and those sorts of things. So how we actually sort of manage, what we're endeavouring to do is in fact trying to keep the exclusive breastfeed rate up. Because if we look at this, exclusive breastfeed each month up to 6 months, this is where our problem lies, that it just falls off the cliff, that we just don't get. Now, some people, the very strong breastfeeding group will tell you that there's problems in the hospital system because people will still have access to formula, or the nurses will say, or the paediatrician will say they need top-up feeds, those sorts of things. What they don't tell them is a top-up feed could in fact be breast milk. But it's early discharge. If you're only in hospital a very short period of time, you haven't had time for your milk to come in, you haven't had time to engage with the health professionals, it may well be something that scares the hell out of you. Yes, you can talk about it antenatally, yes, you can talk about it to school kids, but the problem is most of women who are pregnant are focused on the delivery because that's the issue that they've got to get through. Sure, might have had lots of babies before, but if they've had a terrible experience around the delivery, that'll be their fear. And you've actually got to get them through that process of dealing with those sorts of things and making sure that they've actually got enough information. So we think that in terms of this is what we're trying to arrest, this drop-off, quite significant drop-off, but we don't really understand it enough. And this is where some of the work that you do comes into being. Oop. So in terms of how this all works, the department received funding from the Australian Health Ministers Council for 2 tasks. The first is to seek a national agreement on a process to get baseline data allowing the ongoing monitoring of breastfeeding activities. This will allow the strategy success to be measured over time. The second task is to develop a higher level enduring breastfeeding strategy. Enduring meaning there's no end date. The one in 2010 that was done had a 2015 deadline. Why did they have that? Well, it's probably because we used to have, in fact, just in place for 5 years, but now we're wanting to have no end date, so there will be no need for a process to place regular reviews at this point. But in fact, we need to update. Just like NH and MRC will update their guidelines every 5 years, we think these sorts of things will require some level of input. A key focus is reviewing the current literature to address the barriers to women establishing and maintaining breastfeeding. Because some of us will have a view about that. but what does the overall evidence actually tell us about what are the barriers, what's actually going on within those things? And we think, particularly in Australia, there's cultural issues. Like I've heard from the Aboriginal and Torres Strait Islander health workers, there are issues with young Indigenous girls with shame. The issue of just breastfeeding, particularly in public, that it's actually a very challenging issue. And sometimes people will say that it's quite confronting to see a woman breastfeeding. For nurses, nothing's confronting because you've actually seen lots of things in your life. But for many people, you know, is the client in your waiting room breastfeeding? How does that actually impact on the rest of the people in the waiting room, those sorts of things? And you know what it's like in your waiting rooms because they're actually, you know, they're difficult places to manage because you've got different client groups moving in and out of them. And if you have different client groups, it makes it hard to try and manage an overall general practice. So the project funding came out of RMAC and it came to the sort of two areas. The next bit is important from a governance structure because often we talk about these things but people have no idea how it all connects up from a governance structure. Thank you. That was my 5 minute. I work for the Department of Health. We have the BJOG group, the Breastfeeding Jurisdictional Officers group, so that's National Health Department people represented. I chair that group. And we also have an expert reference group chaired by our Chief Nursing Midwifery Officer, Deborah Toms. We need the experts to tell us if we've got it right. What's the data telling us? What's the latest? All those sorts of things, but also making sure that we talk to jurisdictional people. That reports up to the Standing Committee on Child and Youth Health. And Sky looks after this as a portfolio of areas, and we report to the Community Care and Population Health Principal Committee. RMAC has a range of principal committees. CCPHPC is just one of those principal committees and essentially looks after most of the population health, primary health care, those sorts of things. And they report through the Australian Health Ministers Advisory Council, which is a mixture of CEOs, and then they also report up to the ministers across that. In fact, Minister Wyatt's actually opening, well, he doesn't sit on RMAC because he's not the main health minister, Minister Hunt is, that he sits on, and then that reports to the CHC, which has got all the premiers on. So, we need your input. So what you have in front of you is in fact the draft, very shortened version of the draft document. We're consulting on this in a larger document. The proposed strategies are based on previous strategies. The views aren't endorsed currently by the government. We're just putting it out to the community. It's a community-wide strategy, and we're hoping people have an opportunity to have input. Our next steps. We're in the face-to-face consultation process, and I welcome the opportunity to talk to you today. And we've got feedback on discussion documents that some of you have copies of. There's an email address. We're going out to a broader community consultation in June, and we aim to have this finished by the end of the year with a view of putting it out through the RMAC process towards the end of the year, early next year. These things take time to get through the system, and they're going to take a while to make sure we're getting all the agreements across the board. We also will be, when we go to the community, having this Consultation Hub, and there's a snapshot of the Consultation Hub that Department of Health actually has available to you. So you will be able to, as you look at the information, be able to sort of tap into those sorts of things. And so there's a sort of email address there. What you have in front of you, the documents you've actually got, is the strategy itself. So I've given you copies of this one, so the actual strategy itself, and it goes through. Some of you haven't got it because the room's got larger than I'd anticipated, but we will make sure that, do we have email addresses for most people that we'll be able to get documents for? Look, if you're really hanging out for a copy of the document, email us and I'll make sure you get an electronic version of it. So this is the actual strategy, the discussion document that you've actually got. And this document here, the larger A3 paper, we've been workshopping this over the last few days, as we will be next week in Adelaide and then the following week in WA and Northern Territory, looking at the vision and objectives, looking at the principles and looking at the enabling factors. And we're talking to people to say, have we got this right? Are there things in the principles that aren't there that we're missing? Or can we do a better job with this whole thing? So it's actually there for you to look at. And then as you look on the next page are the strategic priorities of the breastfeeding continuum. So looking at what are the goals, what are the objectives, what does the evidence work, have we got this right? So it's there for you to look at and maybe talk amongst your professional colleagues to sort of see, and we're happy to take feedback. I'm sorry we haven't got more time, and in fact I would have loved to workshop this with you, but there are other people who want to talk to you about mothers and babies. So thank you very much. I think that sort of ends our time because we're on to our next speaker. Is that right, Kathy?
We can take a few questions for Alan today. Any questions?
And no questions mean you're absolutely confused or hopefully going to cover off.
Email Alan and
Yep, that I'm happy to take. And I'm around for the next couple of days, so if people want to talk to me about it on a one-to-one level, I can give you my business card and we can talk further about the work. Yes?
Alan, it's probably quite a clinical question. I'm not sure whether it's appropriate. I've had a couple of mothers wanting to breastfeed through the immunisation process.
Yes.
Is there evidence to show that reduces the stress on children at the time of immunisation?
No.
No?
Not in terms of the baby's being immunised and the mother's feeding through that process, no.
So literally at the time of...
Well, it's really, most kids that take the immunisation, it hurts. So, yeah. And I'm sure many mothers don't want their nipples bitten off when in fact... And biting is an issue, particularly as kids get older. So I would think, no. I mean, I think you've just got to get on with the immunisation and do it. The other thing is about women on drugs. Actually, if they're taking medications associated with, more generally, continue on with breastfeeding. There's some confusion around that, but more generally, we think from a clinical point of view, breastfeeding is best. Now, there will be issues around women on methadone. You won't see many women on methadone. You will see women that are taking speed, but they'll probably will stop breastfeeding because their lifestyle is such that it's so chaotic. Breastfeeding is the last thing they're going to be able to do, and they want to be able to, and really their baby's probably best left with somebody else. And that's often what the case is, particularly when children are taken away from mothers with amphetamine use, is because it's much safer for them to be away. Yep.
We still seem to have mothers coming into the practice, having just had their babies, with conflicting information in relation to breastfeeding, and particularly if the birth is normal, but out of hospital very quickly now, and particularly if it's the first baby, and that seems to be...
Yeah, there is. Absolutely, there is confusion. I know as a midwife that often you'll go and see a mum and she'll say, but the last person said this, and the person behind said that, and the person in front said that, and my mother says this, and my mother-in-law says this. So the issue being is all those voices in their head, absolutely bloody confused. So when they come to see you, they're looking for expert advice. And so we would say ABA is a very good source for information, but also there's a website, the DSS website about healthy babies, so they can actually look at the information online. And often it's actually not the mums that want to look at the information, it's the partners. Because they'll have a distressed mother going, what, how do I do this? How do I work this through? And so the partners will seek information that informs them. The translation of that to the mother and baby is a challenge, but yeah, look, I think it's an ongoing issue.
What was that other website?
The DSS website, the Families website, I think it's called, Healthy Families website. So, but again, email and I'll make sure you guys get it. Yeah.
Can I ask in particular, as I work in Tennant Creek with in an Aboriginal health school, what specific programs have you actually, or where can I...
No, it'll be the Early Mothers program that will be for the sort of Tennant Creek. In fact, we're talking in Alice Springs next week, although it's not Tennant Creek, but yeah, we are talking to Alice. But the Aboriginal and Torres Strait Islander have the visiting home program. That's essentially what we've got to probably do for many support mums at home, is to have this video.
Midwives, are you talking about?
Yes, well, it would be midwives. Sometimes it's midwives, sometimes it's clinicians, sometimes it's health workers.
Yes.
But there's not a program. Part of the challenge is trying to get support for breastfeeding mums on a one-to-one basis. So if you're in the private system or you can afford private, you may well get a lactation nurse to help you. They're not available publicly. And so it's a real barrier, and we see that. And so what we're getting lobbied about is that it should be an MBS item, so you actually can have it. So that may well be, if we get an MBS item, it may well be that you actually have a lactation consultant in your clinic that you say to a mum, come back tomorrow and she'll be here. Come back next week, we're running a clinic. Because what I'm hearing is when the states run the clinic, they're overwhelmed. Lots of women turn up, and I know we've got time. Yeah. So happy to take comments. I'll be around for the next couple of days, so happy to sort of talk with you. Thank you very much for your time. I appreciate it.
Wow, thank you, Owen. Your passion is so evident, and we're really, really appreciative that you're right up there supporting...
As a clinician, as you know, as a clinician, you want to inform the policy people. Yeah.
Fantastic. We really, really appreciate it.